Hi, everybody. It's Mary, the OG Woo-Woo therapist. And as usual, everything I talk about today is not intended to take the place of counseling or therapy, but to highlight some of the issues that could or need to be addressed with a licensed counselor or therapist. None of the information that I'm going to talk about should be used to self-diagnose or diagnose anybody else with a mental health disorder. Only a licensed practitioner can and should do that. So today, before we start, I want to give another cautionary note here. Before we begin, I want to name something important. This episode is designed with people in mind who live with complex trauma, attachment trauma, or dissociation. It's important to respect safety through pacing and supporting choice. That means I will move slowly, I'll explain concepts in a grounding way, and you're always invited to pause, skip ahead, or come back later. Today, I want to talk about polyvagal theory and its application to dissociation. This is an information-dense topic, and I invite you to engage the information in chunks. When polyvagal theory is applied to dissociative disorders, it fundamentally shifts how we understand dissociation itself. Rather than seeing dissociation as avoidance, resistance, or fragmentation alone, polyvagal theory frames dissociation as a state-dependent autonomic survival strategy, specifically a response by the central nervous system to inescapable threat. Dissociation is not a failure of regulation. It is regulation under extreme constraint. In dissociative disorders, clients do not move fluidly between these polyvagal states. They become trapped, oscillating, or fragmented across them. Let's take a minute and talk about what it is to be trapped, oscillating, and fragmented with dissociative states. And then I'll go on to talk about the application of polyvagal theory and the fundamental changes in understanding of dissociative disorders. First, being trapped in a dissociative state is where the nervous system becomes chronically stuck in a dominant trauma-related state with limited flexibility to shift. What I'm watching for clinically is persistent emotional numbing or depersonalization, chronic shutdown, collapse or dorsal vagal dominance, recurrent intrusive re-experiencing or flashbacks without access to present safety, and a fixed trauma identity such as I am permanently damaged. For example, a client who lives in constant emotional flatness and disconnection, who rarely accesses joy, anger, or vitality, their system learned that shutting down was safest, and it never fully came back online. This is often mistakenly diagnosed as a depressive disorder, and clients sometimes will be given antidepressants with no effect. The mechanism at work here is that the autonomic nervous system loses flexibility. Instead of moving fluidly between states of engagement, mobilization, and rest, it remains rigidly organized around survival. Second, oscillating between dissociative states is where the system swings back and forth between contrasting trauma states without integration. What it looks like is alternating hyperarousal, panic, rage, intrusive memories, and shutdown, numbness, and depersonalization. Shifts between competent adult functioning and regressed childlike states, or feeling fine one moment and completely overwhelmed the next. For example, a client who presents as composed and high functioning in session or on the job, then suddenly shifts into intense fear and disorientation when discussing attachment themes. The mechanism here is that the system cannot hold opposing states simultaneously, partially due to compartmentalization. Instead of integration, it flips between them. This often reflects partial structural dissociation, for example, where an apparently normal part and an emotional part take turns. Third, to be fragmented across dissociative states is where the experience is divided into distinct self states with limited communication or continuity between the self states, mostly due to compartmentalization. What it looks like is gaps in memory, distinct shifts in voice, posture, and affect, conflicting beliefs that feel equally true, and a sense of parts or self-operating independently, or multiple personalities. For a client, for example, a client who says, part of me knows I'm safe, but another part is absolutely convinced I'm in danger. And when that part is here, I can't access the rational one that says I'm safe. In more severe forms of dissociation like OSDD or DID, fragmentation may include identity discontinuity, amnesiac barriers, and differentiated self states with unique roles, multiple personalities. The mechanism here is that overwhelming trauma exceeds integrative capacity. Instead of forming a coherent autobiographical narrative, experience is compartmentalized into discrete state-dependent networks, or maximized compartmentalization. Putting it all together, we see these patterns are not separate by diagnosis, but different organizational strategies of the nervous system trying to survive. There is a clear pattern that shows itself. And that pattern is clinically distinguished in simple terms. And that is that trapped equals loss of flexibility, oscillating equals loss of stability, and fragmented equals loss of continuity. All three involve impaired integration, but they differ in how the system organizes survival in the nervous system. Now that that has been explained, let's begin with the application of polyvagal theory to dissociation and begin to think about dissociation as dorsal vagal dominance with a twist. Classic dorsal vagal shutdown explains depersonalization, derealization, emotional numbing, and collapse states. But with dissociative disorders, especially OSDD and DID, these often involve mixed autonomic states like dorsal immobilization with sympathetic activation underneath, shutdown layered over terror, and numbness alongside hypervigilance. This produces frozen alertness, trance states, switching, and amnesia with physiological arousal. Polyvagally, dissociation is not calm. It is immobilization without safety, and this distinction is critical for treatment. Looking at structural dissociation through a polyvagal lens, we see that polyvagal theory aligns closely with the theory of structural dissociation. Apparently normal parts, or AMPs, are often organized around ventral vagal or sympathetic functioning and focused on daily life and avoidance of trauma material. Emotional parts, or EPs, often are organized around sympathetic terror or dorsal collapse, where they hold traumatic memory, affect, and somatic states. Switching between parts often reflects rapid autonomic or nervous system state shifts, not conscious choice. Treatment, therefore, is not about integration first. It is about increasing autonomic cooperation between the parts. This brings us to the question of why traditional interventions fail in treating dissociative disorders. From a polyvagal perspective, many standard interventions fail because they violate autonomic sequencing and are often misperceived in therapy. Many times, traditional interventions like CBT, exposure therapy, and even EMDR can be misapplied to dissociation. The common misapplications include trauma processing without ventral access, mindfulness practices that deepen shutdown, exposure techniques that increase fragmentation, and insight-oriented work during dorsal dominance. These interventions may look appropriate cognitively, but physiologically, they are overwhelming to the nervous system. The result is often increased dissociation, switching, destabilization, and therapy dropout. The core treatment implications for therapists are, first, the ventral vagal capacity is the primary treatment goal. Before trauma processing, memory work, or integration, the nervous system must experience safety in relationship, predictable co-regulation, and tolerable levels of activation. This means there must be consistent session structure, regulated therapist presence, attention to voice, pacing, and facial expression on the part of the therapist, and explicit tracking of state shifts while in session. The therapist's nervous system becomes a regulatory scaffold for the client in session and progenitor for co-regulation to the self states independently. My apologies for that interruption. Second, co-regulation precedes self-regulation because many dissociative clients never developed internal self-regulation because it was not possible developmentally due to ongoing trauma. Expecting autonomous regulation too early reinforces shame, it increases dissociation, and it strengthens the protector parts. Instead, we understand that therapist-led regulation is ethical and necessary. Grounding is relational, not instructional, and that safety is experienced, not explained. The goal is to develop emotional safety through co-regulation. Third, trauma processing must follow autonomic readiness, and polyvagal theory helps answer the question, why does EMDR help some dissociative clients and destabilize others? It is because EMDR requires sustained ventral access, the ability to move through sympathetic arousal without collapse, and minimal dorsal dominance. For dissociative clients, EMDR resourcing must be somatic and relational. Sets must be shorter, stop signals must be honored immediately, and processing may occur in fragments, not narratives. Fourth, we see that dissociative parts can be mapped to autonomic states. In DID and OSDD, different parts often have distinct autonomic profiles where child parts are usually in sympathetic terror or dorsal collapse. Protector parts are in sympathetic dominance, and managerial parts are in pseudo-ventral where there is rigidity. Treatment involves recognizing state-based parts without pathologizing them, helping parts notice one another's autonomic cues or triggers, and fostering internal co-regulation between the parts. It is a fact that integration emerges after shared safety between the parts, not before. Fifth, shutdown is not the enemy. It requires one of the most important polyvagal corrections in dissociation work, where dorsal vagal responses are not viewed as pathological. They are protective. When we try to eliminate shutdown, it increases fear, escalates sympathetic arousal, and strengthens dissociation. Instead, therapy must aim to soften shutdown gradually, create exits from dorsal states, widen the window of tolerance, and allow choice where there was once inevitability. An important clinical reframe for therapists is that polyvagal theory invites us to stop asking, why won't this client stay present? And start asking, what does presence cost this nervous system? For dissociative disorders, treatment success is measured by insight and more reduced switching frequency, faster recovery from shutdown, increased internal communication, tolerance of relational closeness, and moments of spontaneous ventral engagement. Finally, it is important to remember that dissociation is not disconnection. It is survival without safety, and that polyvagal-informed treatment does not force presence. It builds the conditions under which presence becomes possible. Here are some examples of mapping dissociative symptoms to autonomic profiles. It is important to remember that dissociative symptoms are state expressions, not traits. Polyvagal theory helps clinicians identify which autonomic state is driving which symptom in that moment. First, let's look at predominant dorsal vagal activation, where immobilization is the outcome. The core theme is survival through shutdown, or the free state. Physiologically, the experience is low energy, low metabolic output, and reduced sensory integration. Common symptoms experienced are depersonalization, I'm not real, derealization, the world feels flat or far away, emotional numbing, blank mind, amnesia, hypoarousal collapse, loss of time without panic, and passive death wishes like, I wish I was dead. Passive death wishes do not require hospitalization, but are something to keep an eye on with dissociative parts. Clinical risks in treatment are that it can be mistaken for calm, stability, or mindfulness, and the therapist may push insight or trauma work prematurely. The clinical signal for dorsal vagal is presence without aliveness, or seemingly going through the motions with no emotional investment except for fear and terror. We frequently see this with domestic violence, where the abused partner becomes like an automaton. Moving on to predominant sympathetic, where mobilization is the outcome that we most frequently refer to as fight or flight response. The core theme is survival through action. Physiologically, the experience is high arousal, threat detection, and fragmented attention. Common symptoms are emotional flooding, panic with dissociative features, rapid switching, intrusive trauma memories or flashbacks, somatic pain, agitation, and racing thoughts with loss of coherence. The clinical risks are overprocessing trauma, encouraging catharsis without containment, and mislabeling activation as progress. The clinical signal is energy without safety. We frequently see this in staying busy and on the move with activation of the sympathetic nervous system, ready to respond at the drop of a hat or being hypervigilant. This is also common in dysfunctional family systems resulting from alcoholism, where the family members are constantly on guard, waiting for the shoe to drop. Now let's look at the mixed state of dorsal and sympathetic system, which is most characteristic in DID and OSDD, where anxious attachment frequently forms. The core theme is immobilization without safety. Physiologically, the experience is a freeze response and contradictory signals like the person I fear the most is the person I need. Common symptoms are trance states, frozen panic, switching with amnesia, child parts activated without affect tolerance, dissociation with high physiological arousal, and feeling trapped inside. The clinical risks are the push for grounding that worsens shutdown, premature trauma processing that increases fragmentation, and confusing dissociation with avoidance in therapy. The clinical signal is terror underneath stillness. We see this frequently with childhood abuse, where the child complies with stillness but is terrified of being annihilated. Finally, let's look at ventral vagal, the home of social engagement. The core theme is safety with connection. Physiologically, the experience is integrated autonomic regulation, and this is the healthy state of the central nervous system. The markers are coherent narrative, curiosity, emotional range, present moment awareness with choice and flexibility. An important caveat here is that some DID and OSDD clients present in pseudo-ventral states, socially functionally, but internally disconnected. This is not true regulation, it is pseudo-regulation. I spoke in an earlier presentation about the window of emotional tolerance and mentioned it just a little bit ago. Now let's briefly take a look at polyvagal theory versus the window of tolerance. Let's look at where they overlap and where they differ. Both models are useful because they answer different clinical questions. The window of tolerance has the primary question of, is the client inside or outside their capacity of emotional tolerance? The strengths are that it is simple, it normalizes dysregulation, it's a good psychoeducation tool, and it helps with pacing. However, there are limitations in dissociation, and they are that it treats dysregulation as linear, high versus low. It does not explain qualitatively different states. It misses mixed autonomic responses and can pathologize shutdown as out of window. Window of tolerance tells you the client is dysregulated. It does not tell you how. With polyvagal theory, on the other hand, the primary question is which autonomic nervous system is organizing the experience right now. The strengths with polyvagal are that it differentiates collapse versus agitation, explains freeze and mixed states, accounts for attachment and co-regulation, and maps directly onto dissociative structure. However, the limitations with this are that it is more complex, requires clinician self-regulation awareness, it can be misused if treated rigidly, and it requires specific training for the therapist. Polyvagal theory tells you what kind of dysregulation you're seeing, and therefore what not to do. When we look at clinical integration, we can think of it this way. The window of tolerance equals altitude, and polyvagal theory equals the terrain, like the difference between Google Maps and Google Earth. In DID and OSDD, terrain matters more than altitude. In my practice, I use both perspectives with my clients, especially when doing EMDR. Now let's consider a phase-based polyvagal-informed treatment roadmap for DID and OSDD. This aligns with the International Society for the Study of Trauma and Dissociation phase-oriented treatment. but reorganizes priorities around autonomic readiness, not just skills or insight. Phase 1 is to establish autonomic safety and stabilization, which is often long-term, and it is not prep work like within EMDR. The primary goal is to establish ventral vagal access in relationship. Polyvagal targets in treatment are to increase time in ventral states, reduce frequency and depth of dorsal collapse, build exits from freeze, and decrease mixed state switching. The key interventions that are used are therapist-led co-regulation using time, pacing, and rhythm, explicit tracking of autonomic shifts, naming states without interpretation, gentle orientation to present safety or present day orienting, mapping parts by nervous system state, not narrative, and session predictability and structure. All of these interventions combined are how the therapy session is structured. No matter what, it is vitally important to not engage in trauma memory processing without safety and stabilization. Don't push intrusive mindfulness or intensive mindfulness and avoid re-traumatization resulting from exposure-based techniques, and definitely do not force integration. Sometimes these things happen when the client is in a hurry to feel better and inaccurately reports what is going on internally and how they are regarding self-state experiences. Clinical success markers are faster recovery from dissociation, fewer abrupt switches, increased internal communication, and tolerance of relational closeness. Phase 2 is to develop autonomic cooperation with trauma processing. The primary goal is to process trauma without autonomic overwhelm. The polyvagal requirements are reliable ventral access, an ability to move through sympathetic arousal without collapse, and recognition of early dorsal cues or triggers. The key interventions are EMDR with heavy modification, ego state or parts work like IFS with autonomic tracking, short processing sets, frequent reinforcing, stop signals are honored immediately, and processing is assisted by therapist regulation. The clinical focus is not memory completion, it is not catharsis, and it is not integration of states, but it is to have increased internal cooperation and cohesiveness. The clinical success markers are the reduced need for dissociation during processing, less amnesia, and improved narrative coherence across the parts. I frequently talk about this with my clients, like having 10 chapters of a book that are not connected, with the goal of connecting them to establish a cohesive narrative for their life, even if it seems some chapters are still missing or the information seems disconnected between the chapters. Phase 3 is integration or internal parts in alignment with life goals, establishment of identity, and relational expansion. The primary goal is to expand capacity for aliveness, attachment, and choice. The polyvagal focus is strengthening ventral flexibility, supporting emergence of desire, agency, and boundaries, and working with their fear of safety in relationship. The key interventions are relational repair, grief work for developmental loss, like grieving the loss of the mom they always wanted but will never have, identity integration without forced fusion, and support for intimacy, creativity, and play. The clinical caution is that healing may increase anxiety or grief as dorsal protection loosens. That is not regression, it is an indicator of progress. Finally, polyvagal, DID, and OSDD are not disorders of memory or identity first. They are disorders of autonomic survival when viewed through the polyvagal lens. Polyvagal-informed treatment does not aim to eliminate dissociation. It aims to make dissociation unnecessary. In conclusion, there is hope for healing dissociation, but it takes time. Well, that's it for today. If you liked the content today, give it a like and subscribe. I will be moving on to topics in upcoming presentations that are not as information-dense as what I have been presenting so far. Thank you for being here, and I'll be back next week with another topic of interest. Thank you for being here.